Hello, my name is Justeena Adams, and I'm a student at the University of Michigan School of Nursing. Today, I'm going to present to you one of my patients from my clinical placement. The patient is a 74-year-old Caucasian male. The patient is a retired immunobiologist. His current marital status is divorced. The patient's heart rate was 62 beats per minute, his respiratory rate was 12 breaths per minute, and his blood pressure was 142/72. The patient's status is DNR. Please note that the patient is a poor historian. The patient states his chief complaint is chronic back pain. The patient states the back pain is due to a football accident that occurred in 1958, where another player charged him from behind and hit him in the backside. The patient states he went to the hospital at the time of injury for care. The patient states that there was no broken bones, fractures, or sprains from the injury. The patient states that the back pain is still present. When asked to describe the pain, the patient described it as very localized in the lower spine and muscles. The patient also rated the pain as a 10 out of 10 with movement and a 0 out of 10 without movement. The patient states he uses aspirin and home remedies such as rest and heating pad for the pain. The patient states that the back pain has dramatically affected his life as he cannot get out of bed. In addition, the patient's chart states that the patient was declared not safe for home as well as needs maximal assistance for mobility. The patient stated that he was diagnosed with osteoarthritis 15 years ago. The patient describes the pain as being in his hands and rated the pain as a 5 out of 10. The patient states that the pain in his hands is worse with movement and better with rest. The patient states that the pain affects him from performing daily activities with his hands. The patient states that he had hypertension but has been treated for it. Additionally, the patient's chart lists that the patient has been diagnosed with debility, post-traumatic stress disorder, acute prerenal failure, probable major neurocognitive disorder due to Alzheimer's, dementia, and schizophrenia. The patient states he is up to date on all immunizations. The patient does state that he has an acquired allergy to guinea pigs due to working with them in labs, but no additional allergies were noted. The patient states that he suffered an injury to his knee playing football. The patient denies knowledge of the exact date, but states it was when he was in high school. The patient says that he went to the hospital for care, but denies knowledge of any surgeries or the injuries resulting diagnosis. The patient states that he went to the hospital at the time for his back injury, but he said that this ended his football involvement in school. The patient is currently on medication for high blood pressure, acid reflux, insomnia, incontinence, pain, itching, schizophrenia, depression, constipation, vitamin D for bone health, and vitamin B12 for nerve and blood cell health. The patient states he used to smoke frequently, reporting a use of 60-pack years. He states he's been a non-smoker now for 10. He denies use of recreational drugs. The patient admits to alcohol use. The patient states that he was a drinker for 40 years. The patient did not state or deny alcoholism. The patient denies ever having treatment for alcoholism. The patient states he averages drinking about 4 8-ounce cups of coffee per day, and these cups are caffeinated. The patient states that he used to exercise frequently before his back pain inhibited him. The patient states he did sit-ups, push-ups, lunges, toe touches, and other stretches 5 days a week. The patient states he used to not be able to sleep due to insomnia and back pain, but now sleeps 6 to 8 hours regularly. The patient states that he has 2 daughters who live with him or who live in the area and visit him regularly. The patient states that he has a son that lives far away, but they talk on the phone regularly. The patient states he does not have many friends, but this does not bother him. The patient states that before coming to the health center, he lived alone in an apartment. The patient states that being unable to get out of bed creates a large stressor in his life. The patient also refers to being at the care center as a stressor. The patient identifies as a Methodist, but states he has not gone to church in a long time. The patient states that he received his Master's of Science degree in 1962 and got a job in the labs as an immunobiologist. The patient states that before being admitted to the health clinic, he would not see a primary care provider. The patient states that his father died of diabetes at the age of 54. The patient denies any additional family history. The chart, however, reflects that the patient's father did have diabetes, but deceased at the age of 54 from a myocardial infarction. The patient's mother also deceased from a myocardial infarction at the age of 85. There is no additional family history noted in the patient's chart. The musculoskeletal assessment was chosen for my patient because his chief complaint was back pain. He also has a diagnosis of osteoarthritis. The patient states he has always been active, doing push-ups, sit-ups, toe touches, knee bends, and lunges 5 days a week. The patient states he takes pain medicine for his musculoskeletal pain, as well as uses a heating pad for home care. The patient states that he includes dairy in his nutritional intake, as well as takes a multivitamin each day. The patient states that he has joint pain in his hands and knees. The patient states that he has normal stiffness for his age and denies swelling, redness, warmth, or deformities of the joints other than his hands. The patient states that back pain affects his sleep. He states that the slightest movement hurts his back. The patient states that his back pain affects his daily life and causes a lot of stress on him. The patient states that his mother had a history of rheumatoid arthritis. For the musculoskeletal exam, assessing posture, gait, and screening for scoliosis were deferred due to pain. This assessment was done with the patient supine because of his pain. There was some difficulties assessing his muscle strength and range of motion because of this. Inspection and palpation of muscle mass and bone structure was performed and normal. There was no joint tenderness, crepitus, redness, heat, or swelling of the TMJ, neck, shoulders, elbow, wrist, hips, knees, ankles, or feet. There was redness and swelling on both hands' knuckles. There was also erythema and ecchymosis on both legs. Palpation of the spine was deferred due to pain. Active range of motion was tested and found normal for the patient's neck, ankles, and toes. The patient's shoulder passive range of motion was limited upon abduction and flexion on both sides, but more severely in the left. Circumduction and hyperextension of the shoulders were deferred due to the patient laying down. The patient showed limited passive range of motion in supination of both elbows. The patient showed limited active range of motion in eversion and circumduction of the wrist. The patient showed significant active limitations of range of motion in his fingers due to osteoarthritis. The patient could not adequately flex, extend, abduct, or adduct his left hand. The patient could not adequately flex the right hand. Passive flexation of the knee and hip were decreased in the right leg. Passive hip abduction was severely decreased on the left leg and slightly decreased on the right. Hip abduction was equally decreased in both. Muscle strength was tested and found normal 5 out of 5 for deltoids, biceps, wrist, hips, hamstrings, quadriceps, and ankles. Fingers had inadequate muscle strength, rated a 4 out of 5. A neurological exam was best for my patient because he has a history of Alzheimer's, dementia, schizophrenia, and a few other neurological disorders. Upon entering the patient's room, the patient was awake, alert, and responsive. The patient appeared to have decreased personal hygiene practices. The patient's facial expressions were appropriate for the conversation and situation. There appeared to be no difficulties with formulation or comprehension of speech. The patient had a good attention span, never deviating off the exam or the questions. The patient denies numbness, tingling, and burning. The patient denies a history of seizures and losing consciousness. When the patient was asked about his memory, he said that he forgets things, but this is due to his age. The patient denies any problems concentrating. The patient states he gets occasionally depressed, but is mostly seasonal. The patient denies any problems with balance, unsteadiness, and coordination. The patient states he has no sudden changes in consciousness. The patient denies difficulty speaking. The patient denies having any mental health problem. The patient reflects no family history of neurological diseases. For the neurological physical exam, the patient received a 22 out of 30 on the mini mental state exam. The patient had an altered level of orientation to time as the patient thought it was 1993 and did not know the day of the week or the numerical day. The patient had an abnormal intellectual ability as he was unable to count backwards by sevens from 100 or spell the word world backwards. The patient had normal short-term memory, repeating the 3 words said to him immediately. The patient had abnormal long-term memory, however, as he could not recall the 3 words after several minutes. The patient had normal abstract reasoning, normal judgment, and normal thought process. The cranial nerves were assessed: olfactory, optics visual acuity, facial sensory, acoustics Rene and Weber's, and the glossopharyngeal and vagus sensory were deferred because I did not have the necessary assessment tools. Acoustics Romberg's test was deferred due to the patient's pain. The assessments that tested for cranial nerves 2 through 12 were normal, indicating that they are grossly intact. The patient's motor function was deferred due to pain, limited range of motion, and inability to get out of bed. The patient's sensory function was tested. The patient performed normal light touch sensation. The patient had an abnormal painful sensation test, for the patient could not differentiate between sharp and dull pain. The patient had normal stereogenosis and graphesthesia and proprioception tests. Vibratory sensation was deferred due to no tuning fork available. The patient had negative Babinski and ankle colonus reflexes. The first pertinent system I chose was cardiovascular. I chose cardiovascular as my first pertinent system because my patient has a history of hypertension. According to the article, Hypertension, Still an Important Cause of Heart Failure by the Journal of Human Hypertension, hypertension can increase the risk of hypertensive heart disease. Signs of hypertensive heart disease are distended jugular veins, lifts under palpation, an S4 sound, and an S2 split. All of these symptoms can be identified with the cardiovascular system. The second pertinent system I chose was the peripheral vascular system. I chose this system as my second pertinent system because my patient has a history of hypertension, a family history of diabetes, used to be a smoker, is not physically active, and is a male over the age of 50. According to the article Peripheral Vascular Disease and Hypertension, a Forgotten Association by the Journal of Human Hypertension, all of these factors put my patient at risk for peripheral vascular disease. Some of the symptoms of peripheral vascular disease are hair loss on the legs, decreased skin temperature, diminished pulses in the legs and feet, brittle shiny skin on the legs and feet, restricted mobility, reddish-blue coloring of the extremities, severe pain, pallor when legs are elevated, and thickened toenails. A peripheral vascular exam would assess the patient for any of these symptoms. And these are my sources. Thank you.